Narcan in cardiac arrest and faulting EMS for that also.
Yeah, I read that one.
So the same thing. I mean, we're never going to come down and you guys do the program.
You can do what you think is appropriate.
Can't stop you from using the Narcan. Let me know. They're already dead, you know.
Well, I mean, what are you gonna do, spank us for giving us something instead of calling the guy? I mean,
No.
gotta give him something.
That was perfectly appropriate. You have to be able to stand on your own. You have to be able to have a conviction of what you're doing is right. You have to be able to function in that environment where you have people watching you. Okay? So the purpose of what we do in these lectures and these training lectures is to give you confidence in what you say, confidence in handling the situation, confidence in being in front of a group of people, even though you know everybody, but you're able to be in front of them and talk authoritatively and say, no, this is what I believe and this is what I'm going to do. I always have your back, but you've got to prove to me that you know what you're doing. Okay, so far we've not had an issue. I can't say that with every agency I'm with, but so far we've not had an issue. So I will always support you if you do the right thing and think outside of the box. Now if you do something really stupid, you know, publicly I'll support you, but privately I'm going to kick you in the ass. So, but we've not had that. You know, Greg and Bill and the guys that do your training and that look at the run sheets, I mean, everything's been fine, and that's important. Okay, so just some brief anatomy stuff, just very basic. Again, I don't want to spend time with anatomy because it's the physiology that really makes a difference in what we do. And that case is an example of understanding the physiology of the body, the clinical action of the drugs that the patient may have been on, and knowing what to do about certain things, okay? Now, there are other drugs that you couldn't do anything about. I mean, if he was toxic, you know, you'd be kind of limited. So, and unfortunately, I did have a patient that came in who was taking double the dose of his calcium channel blockers, was taking a couple other things, and he came in asystole. I gave him glucagon, calcium, bicarb, and something else. I don't know, this was years ago, I don't remember. And rhythm came back. Within a couple of minutes, he woke up and tried to pull the tube out because EMS had intubated him. And we resuscitated him, and I ventilated him for a little bit, and he was wide awake, so I extubated him, and I started talking to him. He said, well, I was just in the hospital. I said, for what? I was having a problem with my heart, and come to find out, the doctors in the hospital, now you would think common sense would tell you this, but the doctors in the hospital redid his meds, gave him a new list of what he was to take. So he takes his new list, he goes home and takes his meds from his old list and takes them all together. So what do you think is going to happen when he's on a couple of antiarrhythmics? And of course, he ends up, for the previous 3 or 4 days, getting more fatigue, getting tired, pulse rate getting slower and slower, never called anybody. He even had a follow-up visit with his doctor, and he never told the doctor he was taking all his old meds also. So,
Dr. Rodi, you mentioned something that I used to do before, and I totally forgot by now because since I've been here, I've never even seen that drug. Right? I used to give, you mentioned glucagon. I used to give that for calcium channel blocker overdoses and beta blocker overdoses.
yeah, you can use glucagon.
But I forgot what effect did glucagon have in doing, I mean, like I said, it's been since I've been here, I haven't, what effect did glucagon have on
In order to restore the rhythm, is that what you mean? How it works?
Yeah, I mean, how did glucagon help out in calcium channel blocker overdose and beta blocker
It
overdose?
actually is specific for beta blocker overdose, and they don't know exactly the mechanism of how it works. And the dose is more than 1 milligram.
Right.
So how much do you carry? No, okay, well. Normally, we don't carry more than a couple milligrams of glucagon anyway. I mean, even in the ER, we have a, you know, just a few milligrams. So you can use glucagon in diabetics who are hypoglycemic. It causes gluconeogenesis. How does it work in beta blockade? Well, we don't really know because what's the beta blocker's effect? What do they do?
Block your beta receptor.
Okay. So how does glucagon interact with the beta receptors to offset that blockade?
I forgot. Haven't given it 10 years.
Yeah, well, it was not really widely known how it worked. There's some theories about it. We know glucagon increases gluconeogenesis, but how does that offset calcium from the nerve cells?
Does that have something to do with the process of how to release glucogen from the liver?
It has to deal with stopping that beta blockade at the nerve cell level. So how does it do that? And I don't think anybody knows. I've never seen anything, I don't know how it does that, and I've never seen anything written as to how there's some theories about it, but nobody's proven how it works. You know, it's not like a calcium channel blocker. You give more calcium, and the blocker can't offset the new calcium, so therefore, you know, you stop the blockade. But with the beta blockers, not sure how it works. We know that that's the treatment, but we're really not sure. Okay, so I think the important thing about anatomy, and this goes directly to your clinical practice, is understanding how to do a review of systems in determining what the patient's differential diagnosis is. You know what a review of systems is, right? Now, there's more, but for our purposes, we're going to look at this. So, what's a review of systems? It's when you ask the patient questions about each of these specific organ systems. And these organ systems are directly anatomical, obviously. Cardiovascular is made up of what? Heart and blood vessels, okay? Respiratory is what? Okay. So, when you look at these, you're going to ask questions that directly deal with these systems. So, what are you going to ask for cardiovascular? Chest pain, okay? Common. You have chest pain, okay, well, that's going to be the heart. What else? Shortness of breath. Now, where does shortness of breath fit in? We saw earlier it fits in here, fits in here, fits in here. Heme is the blood system. So if you have somebody that says to you, or you get a call shortness of breath, that's why you need to think about all the organ systems that are affected by that. So when you do your review of systems, you're asking questions specific to each one of these. GI, nausea, vomiting, stool changes, bleeding, GU, difficulty urinating, okay? Pressure to urinate but nothing comes out, urgency, hesitancy, blood in the urine, hematuria, flank pain, okay? So when you go and look at your book on physical exam and diagnosis and doing the history and physical, this is an important part of your interview with a patient. And when I ask you for a differential for shortness of breath, you need to know this stuff in order to give me a differential on shortness of breath. That's the importance of this. In these systems, and these are body systems, and they're comprised of anatomical parts and physiologic parts. But in the review of systems, the systems are set up as anatomical systems. The questions you ask deal more with the physiology about what's happening. Okay? When you do your physical exam on a patient, you're looking at the same systems. Of course, we quantify it differently. Head, eyes, ears, nose, and throat. Cardiovascular, your heart and your blood vessels. Respiratory or pulmonary, your lungs. GI, your abdomen. GU, your flanks, urinary tract. Neuro, your mental status exam, numbness, tingling, so on and so forth, when you do the physical. So you see they're all integrated. If you have a patient that says to you, I'm short of breath, you're going to listen to their heart. You're going to listen to their lungs. You're going to ask them, gee, I wonder if the shortness of breath is related to a bleed. You're going to look at their conjunctiva when you pull down their eye and see if it's pale. Look at their skin color. Are they pale? And you know, somebody that's anemic has a different kind of paleness than somebody that doesn't go in the sun. It's a different kind of color. So those are important things to understand it. Anatomically, what you're looking at and what it means physiologically to the patient. So you have to have an organizational menu in your brain. Everybody's different. I have mine that I use for me. You all who do this, I'm sure you have your own that you use. There is no one right system. But whatever you use and however you organize it, it has to work for you. So you don't miss things in your evaluation. Obviously, you need to understand anatomically if you have to do a procedure, so you need to know at least the basic stuff, where the lungs are, for instance, where the intercostal spaces are if you have to decompress somebody. You need to know the anatomy of an airway so you know what you're doing if you have to intubate them or put in a combi tube, which, by the way, as I said 5 years ago, is making a resurgence as being the best alternative to intubation. Body functions, again, through your review of systems, you understand what the different areas do. And then the most important thing are these next two, the physiology and the pathophysiology. We really deal with pathophysiology of disease, and when I talk to you about the different diagnoses, I'm talking to you in a pathophysiologic context, meaning that what this disease does to the normal physiology of the body, and what the medication or treatments do to offset that abnormal physiology that this disease caused. It's a little more complex to do that because you're looking at different parameters, but if you know the basic physiology of what's normal and you understand a little bit about the disease and what it does that makes it abnormal, the rest of it will fall together. And it's actually a lot more interesting to study it that way than to study it the traditional way that medical schools teach it, and that is you learn physiology, which is boring as shit because you don't know, you're a first-year student. You don't know what the hell that means because you don't know anything about medicine yet. So you don't understand why this is important because you don't talk about diseases. It's not until your second year that you start talking about the medical issues. And then you've had physiology and you should have a better understanding of it, but they never stick them together. Okay, they'll tell you about diabetes, for instance, and they'll tell you what it does, but they don't really bring it down to the physiologic level a lot of times. And sometimes you won't put that together. But if you can think about that at your stage, and you understand what it does physiologically and why your treatment does what it's supposed to do, what it's supposed to do in terms of correcting the problem, it'll stick in your mind better. And you'll be able to think of other treatments and other ways of handling something if you have a problem. So that's why it's important to understand the physiology. But more importantly, it's important to understand how the disease affects that physiology and what it's doing to it. So if you have your medic books at home, I don't care which one you have, go to the section on physiology and reread it. You don't have to memorize it. Just reread it to familiarize yourself with some of the basic principles again. And then as we talk about disease and what it does, you'll be able to say, oh, yeah, I remember that. Yeah, I read about that. I know how that works now. Okay, this is basic stuff. I'm sure I don't have to go over that. You all understand what that means. When you do your reports, it's important that you use these terms. Okay, I should be able to pick up a report, read it, and know exactly what you're talking about. The anatomic issues, the physiologic issues, your treatment issues, I should be able to understand all of that. Just by reading the report, I should be able to pick that patient out of a room by what you've written on your report. That's how detailed it has to be. Yes, it's a pain in the ass to do it. I got to do it. I hate those computers, and we have to use computers. It's a massive pain in the butt. It takes a lot of time. And when I'm busy seeing 30 or 40 patients, it really wastes a lot of my time. But it has to be done. Especially when you have an agency that's looking for any excuse to take shots at you. You really have to be detailed and specific. Otherwise, it's very hard to defend something that has 3 sentences in it. And if I'm not mistaken, Chief DeWitt, Wasn't the original report of that patient 3 sentences or something ridiculous?
Yeah, it was.
Now, could you imagine me trying to defend something that has 3 sentences in it?
The cardiac arrest one.
Yeah.
How do you do that and then you look up the
Because, like you said, it's a pain in the ass to do. It's basically got on scene, did CPR, helped EMS, rode in with EMS, patient could be alive. Could be.
Really?
It was that bad.
Yeah.
Wow.
I may be paraphrasing a little bit.
No, it was, because the first report he showed me was 3 sentences. And he said, I got this report, but I told him it had to be redone. This is ridiculous. I agree with you. So, if there's anything I can impress upon you that is really important in this current environment that we're dealing with, you got to put the shit in the report. You got to put it in there. There is no easy way. I hate doing it, but you got to do it. Not only because of malpractice issues, but because without it, we can't defend what's done. If we didn't have all that information in there, what would we say to the idiot at EMS who sends these emails to us about thinking outside of the box and, oh, where'd you get this idea from? Which, you know, in a way, makes you wonder, how smart is this guy if he can't see how this follows, how the progression of this makes sense, that he has to ask those questions? Something to consider. So, you need to be able to use these terms. It sort of separates them into directional, anatomic, all this kind of stuff. No big deal. It's all stuff you know. If you don't, you can review it in your book. Oh, before I forget, there is a national paramedic test that's given for students graduating. You will be doing that test at your certification before I see you. I'll get it to Greg, and you'll be taking that test before you come before me, and you have to pass it. If you can't pass the national certification exam, I'm not going to certify you. So be aware, this is a continuing educational event, guys. You never stop your training, you never stop learning. We do this at the college now. We've changed the program over there. It's going to be a lot more intensive, and in addition, a lot more independent thinking and critical thinking. It's not going to be like it used to be. So, anatomic planes, it's a 200-question test, by the way. All this stuff you see is what's in it, is what's in the exam. So, basically, it's your paramedic book. You understand what the axial skeleton is when people say to you axial loading and axial injuries, you know what that means? Yeah, I mean, it's just, well, that's fine. This isn't a test. This is so that you understand what it means. The appendicular skeleton, so it's very straightforward. Think of appendages and axial, just think of axis of the body. What's it move around? Okay, what are the main structures that move around the spine? Okay. Body cavities, parietal and visceral. Those are the coverings that go inside your cavities. Okay. I want you to understand, because this is actually an important pearl, that when you have patients with certain kinds of pain, they have that pain because of their anatomic structure of the organ, okay? So when you get pain in the spleen or the liver, what does that pain actually come from? It comes from stretching of the covering of that organ, and that covering is called the capsule. Same thing with the kidney. You can have pain in the kidney from a kidney stone, but what is the actual physiology that's happening? That stone is blocking the drainage of the kidney. What's then happening? The kidney still has to take blood in to filter it. It swells. It gets engorged with that fluid. And it makes the urine, well, now the urine can't go anywhere or can only go very slowly, so what's going to happen to that organ? It's a spongy tissue to begin with, so it stretches and swells, and it pulls on the lining of it, which is called the capsule, and that's where the pain fibers are. Okay, it hurts. Patients with liver disease, the early stages of liver disease, what happens to the liver? It swells, so they get pain. It hurts in their back, hurts in their shoulder, hurts in their belly, because that liver's swollen. What happens in the end stages of liver disease? They get cirrhotic. It shrinks down to nothing. They don't get pain anymore. The liver's not functional. A lot of it's dead. So it's important to understand that when you see people with certain kinds of pain and that you think it's related to, and this it's true for trauma too, blunt trauma, they have pain over here from an injury, you got to consider a splenic injury because that spleen has been banged and that organ's going to swell. You can have a subcapsular tear of the tissue because that's just a spongy tissue. It's held together with a covering. That's what holds it together. It's not what's inside of it. That doesn't hold it together. That's what splits. And if you don't have enough trauma to actually tear the capsule and just split the tissue inside, you'll get a little subcapsular bleed, but for the most part, you don't really need to have anything else done. It'll heal. But they'll have pain because that capsule's being stretched. Mononucleosis commonly affects the liver and the spleen, and they get what? They get pain from stretching of that organ, from the swelling, from the mono. So a lot of patients with mono do have hepatitis and liver issues, splenic issues. You can rupture your spleen in mono because it gets enlarged and engorged, so you have to be careful about physical activity. They talk about the body cavities, and we mentioned this briefly. Pericarditis, where does the pain come from in pericarditis? What's around the heart? The sac. What happens to it in pericarditis or in even tamponade, although usually those are sicker patients. But what happens to that sac? Stretches, because in pericarditis you get some fluid in that sac, inflammatory fluid, and starts pulling on the sac and they get chest pain. So not all chest pain is because of ischemia. Again, body cavities. Here it's mostly neurologic. They're talking about dorsally. And thoracically, you've all seen these slides before. Shows you the vascular system, the bony system of the chest cage. Why is this important? Well, if you're going to be decompressing chest, you need to know where those spaces are, where you're going to put the tube. If you're going to be putting in central lines, and even nowadays, even in the hospital, most physicians can't do a central line. They either send them to radiology where it's done under fluoro or ultrasound guidance, or some of them know how to look at an ultrasound to find the vein to put the central lines in. Guys that were trained when I was trained and the way I do it, they're very rare anymore. Very few doctors can put a central line in blindly. You have to know the anatomy. Otherwise you're sticking it who knows where. And unfortunately, for the last 10 years, guys coming out of residencies, they don't know the anatomy because they don't do them that way anymore. You know, probably medics, for the vast majority of cases nowadays, do blind procedures and get the lines in, central lines. But you know the trend is more now towards IOs and that type of thing, because all you need to know is some basic anatomic parameters. And it's faster. Central lines only can be done if you have the experience and knowledge of the anatomy and you do them. If you don't do central lines, you're never going to get them in because you forget the anatomy and the procedure. It's the same thing with intubations. Chest tubes are a little more anatomically oriented, so they're fairly straightforward. The abdominal cavity, when we talk about belly pain, and I talk about the book written by Sir Zachary Cope, Diagnosis of the Acute Abdomen, that is the diagram that he has in his book. And it's important for you to know and understand because this is how you can determine what's going on with the patient who's got belly pain. Now, in this particular slide, they talk about the organ systems that are in each of these areas. So this is important. You should find this in any of your paramedic books. It should be in there. Again, it's using anatomical structure to define a disease process. And that's important when you make a determination in a differential diagnosis. This is some more philosophy. which we already deal with this in a different way, pathophysiology. You all know that, how the body is structured. This is just basic stuff. We don't need to know this. Don't really need to know that. You need to know some about general functions because that's physiology. Okay, so you know the cells function at in a certain way. You remember the Krebs cycle, TCA cycle, citric acid cycle. Yeah, it's boring as shit and sometimes it's complicated as hell. But it has a purpose in understanding how things work, how the body functions, how medications work. Some of them work at a cellular level. Some of them don't. Some of them work at a higher level of function. But the majority of them work at a cellular level. They do something to the cells of a particular organ system to affect a change. You don't really need to know so much. When they talk about movement, they're talking about movement in and out of cells, the cell walls. Conductivity is the electrical activity of that cell. All cells generate an electrical current. Absorption is the ability of that cell to absorb nutrients, proteins, electrolytes, or medications, or toxins. Secretion is the cell's ability to secrete certain substances into those organ systems. Excretion is the elimination of waste products of metabolism. Respiration is their aerobic capacity, and reproduction is the cell's ability, of course, to divide and make new cells. Basic cell structure, again, stuff that you already know. The membrane that covers it, what's intracellular and extracellular. So I ask you the question, is anything important to know that's intracellular or extracellular? How would that determine what you do? Have you heard those terms before in a disease process? You have, but you may not realize it, but you've heard them. We talk about certain kinds of disease processes. Ray talked about CHF and about that fluid leak. He didn't call it a capillary leak, but that's what it is. What does that mean? He told you the fluid fills up the lung. How does it do it? Where does that fluid come from? Where is it going? Okay, is it going into the cells and causing them to swell and oppress the airway? Is it leaking out into the space between the lung tissue and the chest wall? It can. You can get pleural effusions that are from congestive heart failure. Not a good sign, but you can get them. Treatment's different. Not all CHF is treated with Lasix. Doesn't always work because of where the fluid shifts occur. You've all heard the term third spacing. What does that mean? I know you've heard it. Okay, so it's in that space, well, let's call it no man's land, that's out of the cell, not in the circulation, but it's in the tissue around the cells. No, but think of, not subacute emphysema, but think of lymphedema. Think of big swollen extremity. And they're not in heart failure, but the extremity's swollen because that fluid is just sitting there and you can't get to it. Many patients in stage 4 pulmonary edema or CHF do the same thing in their lungs. They get that leak syndrome and it fills their lung tissue up and they can't get to it with diuretics. What do they do for it? The old days we would give them albumin to try to suck that fluid back into the cells and get the cells then to excrete it into the circulatory process and get it back to the kidneys and out of the body. It worked for a period of time. Patients with liver disease, what happens to them? What is this? Big bellies they get. What's that called? Ascites. What is that fluid? Where does that fluid come from? It leaks out of the peritoneum. Just leaks right out of them. One of the old forms of dialysis we used to do is called peritoneal dialysis. The peritoneum is a semi-permeable membrane, meaning that it can absorb fluid and it can secrete fluid. We would put a catheter into their bellies, permanent catheter, they'd connect them to a machine and it would circulate dialysate solution in and out of their belly to pull fluid out of their peritoneum and get rid of the toxins. You don't see much of it around anymore. Why is that? Well, it's because hemodialysis pays a lot more money. And these centers that are owned by all the nephrologists make a fortune. So why would you put somebody on home dialysis with a tank-off catheter and the little machine and their 2 bags of fluid every day to circulate and get rid of their toxins, and it costs maybe $100 instead of doing a $900 dialysis, 3 or 4 times a week? Actually, it's more than $900, but that's what's wrong with medicine.